This conference will now be recorded.
Okay, this is our Tuesday, May 9th edition, 2023 of our ANCAN Advanced Recurrent Prostate Cancer Support Group. My name is Peter Kafka, and I'm moderating this from Maui, Hawaii. I will change locations to Minneapolis next month when I moderate. Here I am now still. I want to mention our sponsors quickly that we're very thankful for because they've provided substantial financial backing for us so we can continue our work. As you know, almost all of us are volunteers. None of us are paid to do this. We're just passionate about helping each other and providing peer support. So amongst those are Bayer, Pfizer, Myovant, Foundation Medicine, Janssen Pharmaceuticals, Telix, and Myriad Genetics. And, they not only make some of the products that we all use and support us in that way, but they also see the value of peer support and have been generous the past year or two in helping us out, which is unusual and a new step for pharmaceutical companies and medical companies to go beyond just supporting research. So we're thankful for them. So I think I've caught most of you. Gary Peters, do you have anything tonight?
Hi, Peter. No, thank you.
Okay. And Herb Courtney, do you have anything tonight?
Not really, no thanks.
Okay. Bob McHugh, do you have anything tonight?
No, I'm good, Peter. Thank you.
Okay. I think I've got everybody then. Is there anybody I missed polling to ask if they wanted to bring something up tonight? I might have missed somebody. Speak up if you have. If you want to be. So I don't want to miss anybody. It looks like we're gonna have time tonight. Okay, so we're gonna get rolling here, and let me just read. Okay, I see one new person. I was given a heads up on Mr. Dietrich. It's Rick Dietrich, and he hails from the state of Wyoming. We don't get too many participants from Wyoming. And, Wyoming is the Wild West in many ways, and particularly in terms of prostate cancer. Not only do we not get many men representing Wyoming, but I don't know many treatment centers or avenues for treatment in Wyoming. And someone joining our group from Wyoming with advanced prostate cancer is unusual, and we want to support you the best we can, Rick. So I'm going to ask you some questions to get it rolling. Somehow you've met Joe Boardman. Is that correct? That's how you found out about us?
Yes, I was referred to him by a friend, and
Okay.
we hit it off quite well because we are from and have lived for a very long time in the same town.
Okay. And what town in Wyoming are you from?
Du Bois, Wyoming, in the Wind River Valley.
Oh, Wind River. Okay, so you're on the eastern side, yes?
Correct.
Yeah. Okay. Yeah, I lived in Colorado for many years, and northeastern Colorado, so I'm familiar with some of Wyoming there for sure. In fact, I was up went through there last year through the Wind River area. How old are you, Rick?
71.
71. Okay. And when were you first diagnosed with prostate cancer?
6 years ago.
Okay. And at that point, what was your PSA and your Gleason score when you were diagnosed?
My PSA was in the high hundreds. It was a total surprise to everyone, including me. And I only went there to the hospital for the first time since I was born, never been in a hospital all those
Right.
years of living. And they said, you've got badass prostate cancer and you're metastasizing, and we got to put a stop to it right now.
Okay. And where were you diagnosed?
At St. John's Medical Center in Jackson, Wyoming, a wonderful hospital.
Okay, that's quite a journey for you though. It's the other side of the state. Yeah.
Well, no, I lived in DuBois. It's a 75-mile drive over Togedy Pass and down into Teton National Park and into Jackson. And as soon as they found out that I had what I had, I was airlifted to Huntsman Cancer Center in Utah, where I was treated like a king.
Okay. Is that in Salt Lake?
Correct.
Okay. And what did they do there? What kind of treatments have you had?
Immediately got a full CT scan, and they saw the cancer had cut off my left kidney with a tumor. They tried to fix it. They couldn't. Lost the left kidney. But right one is still functioning great 6 years later.
Good.
And they also figured out that there was a small prostate cancer tumor on my thoracic T9 area of my spine, and they got rid of that tumor. I'm really making this a short story. They got rid of that tumor, fixed up my spine, everything went beautifully. But I still had PC. And so they thought, you don't really have much choice. You're going to have to do Lupron. And I did, and it worked like a charm.
Okay. Did they put you on second line stuff or just Lupron?
Lupron to start, and a few years later, kicked in Xtandi.
Okay.
I've been tolerating all of it very, very well.
And so you're still on Lupron and Xtandi?
Correct.
Okay.
But 6 years later, only just recently, it's losing its effectiveness. And I've gone from the teens, steady teens, unchanging with my PSA, and now it's jumping up. Not really fast, but it's jumping up enough for my oncologist to want me to start thinking about docetaxel, which I completely and utterly understand everything there is about that chemotherapy treatment. But something very interesting has happened to me, and just recently I've had a couple of blood tests in just the last month, and all of a sudden my PSA is going down. And so that is a very curious thing to all of us, and we're just going to have to wait and see. So I am in a wait and see. I'm not going to do chemo yet.
Good. So what, is your oncologist, your medical oncologist still in Utah? Is that who you're working with
No,
still?
no, now I live in Dayton, Wyoming, just at 4,000 feet, right up by the Montana border in north central Wyoming, and near the town of Sheridan. And there's
Right.
a cancer center, Welch Cancer Center, and that's where I get my Lupron shots. And of course, the Xtandi is prescription through the mail, and that's where my oncologist is.
Okay. Ah. So, and I'm guessing you never had a biopsy. You don't know what your Gleason score was or anything like that. You were just
Well,
diagnosed, you know? No.
actually, yes, they gave me a Gleason score years ago. I really don't care about it. I don't know what it is. I'm sure it's in the records. The fact of the matter is, it just said you have really bad
I
prostate
get it.
cancer.
Yeah, you do.
Yeah, there you
Right.
go.
Okay.
But
Did they do any genetic testing on you?
yes, I got all of the genetic testing. I didn't. Nothing could happen there.
Okay. Well, that's good. Um, and what's your quality of life like now? I mean, you've been on Lupron for quite a while, and
My quality of life is just excellent, and it has been for many years. I've tolerated the hormone therapy really well. I've been very stable, even though they thought this was going to be a super rapidly growing cancer, one way or another, between my diet and my lifestyle and the hormone therapy. I've I've done great. I actually feel quite wonderful. I don't have any bone pain. My oncologists are rather surprised I'm doing so well, but I also live a really clean lifestyle and I grow virtually all my own food. I have a super good diet. I have a calm rural lifestyle,
very
but
good.
while cancer is still inside of me and it wants to get the upper hand, but for some crazy reason, all of a sudden, a couple months ago, my PSA jumped up into the 40s from the teens where it was just stable. And I was doing great. My metastases were not growing, but my bone was getting stronger, and according to scans. And then it got into the 40s, and my oncologist said, you got to start thinking about chemo. And then just at that time, I had another blood test start going down. Then 2 weeks later, it went down another 10 points. I actually don't know what's going on, but I hope it's something wonderful. And I do plan on meeting in the next couple of weeks with my oncologist, getting a blood draw, PSA test. And if it keeps going down, I'm not going to start chemo, especially when I feel great.
Okay. So, yeah, we're gonna open it up to the guys here, but um, I'm guessing. I mean, I kind of I hear you say that you feel like you've got a pretty good oncologist up in Sheridan. Uh, I don't know if it's he or she, but I'm guessing they're a general oncologist who doesn't particularly specialize in prostate cancer, although I could be wrong. Uh, but one of the suggestions that's going to come up because of the uh, the degree of cancer that you have and the oddity of it is that some of the guys are going to suggest that you hook on to a specialist. There aren't that many in the country, and I don't think there are any in Wyoming, or I'm not sure where the closest one is. Was really on the ball with this, but you can even do a phone consultation to get a second opinion, because there are some doctors that many of us use that are pretty big experts in this field, and because you've got some very unusual characteristics here, particularly with the PSA jumping around like it is. So I'm going to open it up and see if anybody has any comments for Rick and thoughts about this. Have they ever seen PSA dropping 10 or more points? How often are you checking PSA?
Every 2 weeks.
Every 2 weeks. Well, that's a significant drop. So, anybody have any comments or thoughts on this?
Well, I would have two thoughts. One, it depends if it was the same company doing the measurements. That's one thought. The second thought is are they doing any scans to see what has reemerged? So those are my two questions or issues. Thanks.
Do you want me to
Have you
answer
had
that?
a PSMA PET scan?
No, no PET scan, but I did just have a MRI on my thoracic spine, and that was one of the places where I had a tumor early on 6 years ago. They got rid of the tumor, and the on radiologist report said he sees a vertebrae that seems to have some disease in it, and it's approaching the spinal cord, the column, but it hasn't got in there yet. But he also said he can't really tell if it's shadowing or not. And so I've had CT scans, I've had the MRI, I've had bone scans. I'm really very stable. I'm mostly concerned about the spine shadowing that they think is disease on the MRI. And I looked at the pictures of the MRI and it's incredibly detailed, but I feel fantastic. So uh, I'm going to get another MRI and see if that shadowy area on my spine has increased in size. If it starts advancing toward my spinal canal, that's when I'm going to have to think about docetaxel, chemo, because I know that will shrink it if it's cancer.
So the first problem, and the reason the guys are saying PSMA, Rick, is because you're looking at this disease from 10,000 feet, and we need you to be looking at it on the ground. And the scans that you're doing aren't providing as much detail as they could if provided that you express PSMA, which is a protein on the surface of the cells. And that really now is standard of care. And the concern I think that most of us have is that whilst you may have a good doc, in your view locally, your care has been lacking even according to standard of care. And most docs would not allow you to stay in the high teens, and certainly not get up into the 30s or 40s. I mean, you should be, if you're stable, that stable level should be probably a lot lower than the teens. Now, the first step is to get what's called a PSMA scan. And that's really what your local hospital, I'm pretty sure they can probably access PSMA scans up there. I can look on the map, but I have a map of where all the radionuclide pharmacies are. But you need that in any event as a baseline, because going forward, any sort of treatment is going to continue with PSMA scans. And you cannot really compare a PSMA scan to an FDG PET scan, and certainly not to a bone scan. So the first thing is you've got to get a PSMA scan. The second thing is that I think most, I'm going to use a phrase. Somebody will put it in the chat window for you. A genitourinary medical oncologist. We abbreviate that to GU medical oncologist. But you need a GU medical oncologist who specializes in prostate cancer. And the reason for that is because the science and the protocols are moving so quickly that your guy in Wyoming, it's hard for him to keep up when he's treating all types, which is why he probably hasn't been doing what we would like to see him do. Now, a GU medical oncologist, probably closest to you, is going to be back at Huntsman. And we can make some recommendations at Huntsman for you. But ideally, what you want to do is find somebody who will work with your local guy. And probably at Huntsman, they're willing to do that, but you've also got to talk to your local guy about it, because if he isn't willing to take guidance from a specialist in this field, he ain't the right guy for you locally. So what you've got to do is find a team, and I'm dealing with this right now in another situation where somebody has brought in a specialist, and the local guy is just not it hasn't bought into the program. So we got to get them into the program. So the next thing that probably a good GU medical oncologist would be talking to you about is what's called debulking the primary. You've never had any treatment of your primary tumor. And nowadays, this isn't how it was 10 years ago, but nowadays they think it makes a lot of sense to treat the primary, probably with radiation. And that's a discussion that should definitely be had. Now, your disease is unusual in that it went to the kidney. We don't see a lot of disease going to the kidney.
No, it didn't go to the kidney. No, it didn't go to the kidney. It was just a crazy little thing in the ureter. It made a little tumor in the ureter. It didn't go to the kidney. They couldn't clear the ureter. The kidney atrophied.
Okay, but even seeing tumors in the ureter with prostate cancer are fairly unusual. That's unusual. Kidney, the tumors go to bone, like ribs, like spine, like pelvis. And if they do go to soft tissue, the most often place we see them is certainly in the lymph nodes. And we see them in the lung quite often. But it's not unheard of, but it's unusual for it to go to the ureter. And
So that's interesting that you say that, because at Huntsman they were totally surprised and they thought, well, this is a crazy little tumory thing. And they didn't even think it was prostate cancer related, but
well,
they assumed
that's why.
it was.
That's exactly why, because we don't see it now. That tumor, and I don't know whether you could do it now, that tumor should have been sequenced, should have been sent away for genomic sequencing.
Yes, they did do that.
And
they did the one that was on my spine too.
Okay, so they sent it away somewhere and they got the results back. Do you have copies of those results?
They're I keep copies of everything of my medical records, but I don't keep copies of any of that, because that company that they send it to check for genetic stuff, all of that is in the medical records in my local cancer center.
Okay, well, you get a copy of that and keep that in your records. That's going to be very important information. Also, find out what your Gleason is. And the reason for that is that it gives us an indication, and it gives the doc an indication of how aggressive your disease is. A Gleason score of 4+5 has a very different connotation to a Gleason score of 3+4. And so it's just important. It is important information to know. So first thing I would say is a PSMA scan. Second thing is discuss debulking the primary. Third thing is possibly switching the androgen receptor signaling inhibitor. You're on enzalutamide. It might be a good time to switch that. But these are all
No. I take Eligard shot and Xtandi.
Well, that's what I said to you.
Okay.
Enzalutamide is the generic name for Xtandi.
Thank you.
Okay. All of these drugs have two names. Some of them three. Where's Ben? Ben's going to come in now and give us a lecture because I never get it right. And Ben told us why they're all. But Ben, what is the reason they're all called amides or tamides? What's the reason? Tell us again. Go on. Tell us why they all finish in apalutamide and enzalutamide, and what you told us the reason, and now I forgot it. Where are you, Ben?
He doesn't want it.
Oh, is he not there?
I'm struggling with my phone. Yeah, they end in lutamide because that's that's the standard generic suffix for non-steroidal antiandrogens.
There you go.
So
Non.
going back to the very first flutamide and bicalutamide,
There you
all
go.
the new ones are going to be lutamides too.
There you go. So that's why they're lutamides. Now you call it extendi because it's easier. We sometimes call it ends. But the point is that if the ends is starting to not to work so well, there are two reasons to get off of it. The first is that you may respond better to another drug. The second is we have seen, and Pfizer knows this, and the doctors know it, your guy up in Jackson may not, that when you stay on these drugs for a long time, and you've been on enzalutamide now for 6 years, am I right?
No, only 3 years. They just kicked it in 3 years ago.
Okay, so even with 3 years, your disease can move into a form where you can't find anything else to treat it. So you need to keep the cancer off balance a little bit. And we've seen guys who have been 4 or 5 years on enzalutamide, and then we can't find anything else to treat them with. So, this is the sort of discussion that more sophisticated discussion that you're going to be able to have with a doctor who's a genitourinary medical oncologist. The guy I would suggest, he's really good, is Niraj Agarwal. I will put his link in the chat window for you in a moment. The chat window are those two little boxes at the top right. And if you click on those two little voice things, it'll open. And give me a second. So I've said a lot, and I know there's a bunch of people want to talk. Jeff Marchi, and I think Mike. Anyway, go ahead. Somebody else.
Jeff, go ahead.
No, I was just going to talk about getting the Gleason score. But that above a 7 means that your cancer is aggressive. That's why you want to find out what your Gleason score is. The higher it is above 7, the more aggressive it is. If you're an 8, more aggressive. If you're a 9, even more. So you want to know that so that you know how quickly your cancer, that's why the surprise is not growing. But by the way, the way you're eating is a major factor is why your cancer is not growing. I mean, being a vegetarian, it sounds like just all the benefits, an incredible amount of benefits of lowering your PSA rise by being vegetarian. Broccoli is a really big booster, but they've come up with super broccolis, which really help. But that's all.
So
more
Rick,
information.
this is Peter again. I just want to emphasize in your situation the importance of a PSMA scan. I mean, if you've got something showing up on your spinal column there, you really want to drill down and know how big, what it is, all as much information as possible, because that's not a good place. I mean, many of us on this call know people with prostate cancer who've ended up in wheelchairs because of metastasis on the spine. It puts pressure on the spinal cord. So we can't emphasize enough to find a really good expert, and you don't have to go someplace. Sometimes you can just have a consultation on the phone and send all your records to them, and they can work with you, and work with your local doc if he's willing as well, because you want to watch this disease. I mean, as Rick Davis mentioned earlier, you've got a pretty peculiar situation, and all of us are somewhat unique, but yours is pretty peculiar in some of the things you've described, and and how it went to the ureter, and now the Mets on the near the spinal cord. So even though you're feeling great, this disease can bite you in the butt overnight. I mean, it's not something to mess around with, and we want to support you the best way we can. So you're in a, I mean, you're up there in northern Wyoming, and it's it's God's country, but it's like where I live, you don't have the best medical care. I mean, I live all the way in the Hawaiian Islands, and you better believe I made a beeline for California when I was first diagnosed to get the best medical care I could, because this is your life. And if you've got the resources and the insurance to cover it and everything, you want to get the best eyes on this as you can.
Yeah, Rick, I'd like to also second what other Rick said. I, for a long time, used a general oncologist, and her kind of approach was just to sort of wait and see, because my PSA doesn't express PSMA, so those scans were negative. But she just said, well, rather than treating just a number being the PSA, she just kind of wanted to drift along. And through this group, I hooked up with a GU med onc at UCLA, and he immediately took charge because that's all he does is prostate cancer, and put me on Lupron and darolutamide, and my PSA is way down, my testosterone's way down along with it. And so the PSMA PET scan is the most sensitive scan I think we have today if your PSA expresses, if your prostate cancer expresses PSMA. But I don't know, Ancan, Rick, if you know the percentage, but I've heard everything from 10% to 30% of prostate cancers do not express PSMA.
Yeah.
So if you get one and it comes up totally negative, that doesn't mean you don't have it. So those are my comments.
Alan Babcock, you've got a comment.
Now, I was going to ask Rick. Rick, do you have any questions for the group? I mean, you just came to this group. You've had a lot of stuff thrown out there. Do you have questions for the group?
Yes. I'm just sort of assuming some of you have done the chemo, docetaxel chemo, or maybe not.
You're right. Some of us have, and we've weathered it. Yeah, Pat Martin just raised his hand. I've done it. Quite a few. Raise your hand if you've done chemo. Look at that. There's a fair number of us. It's not the worst thing in the world. It is it's a wild ride. It's worse than the Bronx at Frontier days. It's pretty bad, but you'll get through it if you need it.
So did any of you have to go to the hospital in an emergency room for infection because of the over 100, temperature?
The answer is some of the guys did. I don't know if they're here. Dennis Correa is certainly one. I don't know if there's anyone else here, but they did. But I think you're getting ahead of yourself. I think that before, you may well be able to control this drug without doing chemo. I mean, your local guys talking about blunt instruments here. And what we want to do is introduce you to some more finesse in how how to be treated. Now, you can plunge into chemo, but that's probably how you would have been treated 7 or 8 years ago. The treatment is different now, and your guys are still in the dark ages. And yes, if we would have put someone in, we probably would have put someone in chemo. But there's some other issues too, and with the nature, we got to make sure we get the right chemo. And with the nature of your original tumors, that might raise some questions too. That's why we really want to see you go to a specialist.
Okay, so I totally get that point. I'm writing this down, and I do want you all to know I do have an oncologist who fully encourages me to get second, third, or whatever other opinions I can get. She's not trying to hold me back or push me into chemo. even though it is her job to orient me with it if I were to make the choice. But I've done so much research myself that I'm completely aware that there are other options than that. So even though they're encouraging me to do chemo, I know it's not time yet. So yes, thank you for that. It's not time for me, and I'm just not gonna. I'm going to get more information, and here I am today doing something I have never done before. I'm on ANCAM, and thank you.
Uh, and we're here to support you. We meet weekly, but if you've got questions that come up, you can email me or Rick Davis or any of us, and don't feel alone out there, because many of us have gone through all kinds of stuff, and this is a manageable disease if you're on top of it. So it's not a curable disease, but it's manageable at our level.
Yes.
And you'll go on for a long time.
I mean, I think one of the things, hold on, I'll come to you. I think one of the things you need to talk to your oncologist about is, what is a reasonable, stable level for your PSA to settle at, and it just the high teens, low 20s just sounds. We're not medical docs, but from our experience, that seems a little high. I mean, we've not seen that before. Anybody going through long periods of time with metastatic disease in the high teens. It may just be a function of you, and you may be a PSA guy, a guy that makes a lot of PSA, and we've had those. But it certainly would raise a question. Somebody wanted to get in. Who was that?
Yeah, that was me, Rick. I wanted to ask Wyoming, Rick, a few questions, see if we can figure out what's going on with this PSA bouncing up and down. So first of all, can I ask you if you know what your PSA nadir was, the lowest PSA post-treatment that you've ever had?
7.
Okay, and how long ago was that?
6 years ago.
But that was after treatment. It was 7. Yeah, you said you were in the hundreds.
All of the oncologists in the prostate cancer center at Huntsman, after I started Lupron, which I totally knew what I was getting into, not a problem. Been married 36 years, not a problem. They were totally surprised that I reacted so well to it, and all metastasis came to a screeching halt, and my bones started to rebuild. And since then, every 6 months, bone scan here, CT scan there, bone scan here, CT scan there, no advancement of anything.
What did anything change in your I don't know, your exercising regimen or your diet when you were stable in the teens on your PSA and suddenly it jumped up? Anything change there? Like were you riding a bike before you never did? Something like that?
No, nothing like that.
Nothing
Lifestyle
changed.
didn't change at all. I was leading a very healthy lifestyle when I was diagnosed 6 years ago, and it's just gotten better and better. Now I eat better than ever, even though it was hard to improve upon that from my previous life. I grow all my own food. I eat only locally raised beef. I have a very excellent diet, and
Right.
I take lots of cancer cell inhibiting herbs and spices. I take lots of that. And so what my oncologists have told me, and I do plan on getting more, stepping up after coming to this meeting. Right now, my general oncologist woman, Nina, she says that If you just keep it stable, and this was a couple of years ago, I was at 15. She goes, well, as long as it just stays at 15 every single month, and we're doing a blood test and it's 15, 15, 15, and you're getting CT scans, and you're getting bone scans, and nothing is showing up bad, and even a little bit of bone rebuilding, then we're good to go. Let's just hang out here. It's only been just recently that all of a sudden it's going to 25, 35, and then it got up to 50. And then all of a sudden I started doubling my herbs and spices that are anti-cancer on the top 10 list of anti-cancer herbal things. And I didn't change my food diet. And now it's going down. And I do plan on meeting with my oncologist, and I'm not going to, I'm going to try to figure out what, is it going to keep going down? I don't know.
Well,
Rick,
you should be
does she
aware
have you
that
on any kind of bone strengthening drug? Are you taking
No,
anything?
no zoledronic acid. I learned all about zoledronic acid. They did suggest that I might get on it. I learned all about it from my dentist. I don't need it. I'm not arthritic. I'm very, very active. I do all kinds of stuff. You'd never know I had PC. I don't have any bone pain. And my dentist told me she's an expert on zoledronic acid. And she said, as soon as you start that, anything that happens in your mouth, you've got all four wisdom teeth. If you have any kind of dental problem, we're never going to be able to help you. And I also do not believe zoledronic acid is a benefit to me at all right now, because my own bone has been proven to be rebuilding itself in previously metastatic spots.
So Rick, the one thing I would caution you about, the supplements that you're taking, sometimes they can affect your PSA. They can mask the PSA. And just because your PSA is dropping doesn't necessarily mean the cancer is going away. It's just not producing, it's possible it's not producing PSA anymore. So when you switch to a GU medical oncologist, as we all hope you do, you should mention all of the supplements that you're taking, and or you can even run a search yourself at drugs.com/interaction, I believe is the website, and you can plug in the drugs you're taking and the supplements and see if they interact with each other.
Very good point, and I plan on doing that. I'm going to call Huntsman tomorrow and make a Zoom appointment with their GU medical oncologist. I'm in their system. They know who I am, and Dr. Ward there and his staff would know me well. So I'm going to reconnect with them and do what you said. It makes this great suggestion.
Okay, great. Rick, keep in touch with us. If you need to contact us, Rick Davis's email is rd@ancan.org. Mine's peterk@ancan.org. Just keep in touch with us, because and let us know how you're doing and what's up. We're going to move on to some of the other guys. But we want to support you the best way we can. You're a strong guy, and I admire that. We all admire that. But as I said, don't let this thing sneak up through the back door on you, because it's a sneaky disease sometimes, and you've got some odd characteristics, and we all feel for you. Okay?
Thank you.
Okay.
Nice to meet you, Rick.
Nice to
Okay.
meet you all.
Yeah. Alan Babcock, go ahead.
Yeah, real quick update. I had my first PSA since I stopped the Orgovix and radiation, and my PSA was undetectable. I'm not as impressed with that as the doctors are, because I fully expect it to go up at some point, but I'm going to get as much time out of it as possible, and I'll get another PSA in 3 months. So that's where I am right now. I'm not worrying about anything. I'm just going to enjoy life for the next 3 months and then see what happens then. That's
How
it.
long have you been off Orgovix?
3 months since February.
3 months. Okay,
Yep.
good.
So, but I can tell my testosterone's coming back, so that's kind of good. I'm feeling great. So I'm happy where things are now, but I'm prepared for things to, it's somebody said earlier, it's not a curable disease. My doctors use the word cure. I always correct them. Yeah, I don't think so. And I'm not looking at it as a curable disease. I'm looking at it as something that I'm going to manage the rest of my life.
Very
I'm
good.
curious, Alan, what's your first hint that your T level might be coming up?
When I was in bed with my wife, I had an orgasm.
Okay.
Okay.
Sold. Okay.
See how fast that is compared to the stopping Lupron?
Oh,
Yes.
the doc told me that the Orgovix, man, when you stop it, usually stop it, it really stops really fast and your testosterone starts going up.
Yeah.
Okay. Thank you. Mr. Maloney, you want to talk about, you're in the middle of the Pluvicto cycle.
Yes, thank you. My microphone's slow coming on here.
You're good. You're good.
Okay, thank you. I've had 3 Pluvicto cycles now. After the first, my PSA went down quite a bit. After the second, it went down some more. And then 2 weeks later, it came up again. I'm saying, well, why isn't it staying down? I don't know if this Pluvicto is effective for a long time.
Well, some guys get some mileage out of it and some guys don't. And good question.
But just a couple of
Anybody
weeks
been on
after.
anybody been on Pluvicto that wants to speak to?
Well, I can talk for a moment. I bailed out, as you may know. I was having, I don't know if I mentioned it, this group, I'm in so many groups. I was getting weird, well, not weird side effects. One was on my right leg. I got edema, hasn't gone away. I've had about 4 or 5 side effects. So since my PSA was not really going down much, I bailed out. And I'm waiting to get a PSMA on May 22nd. See what happens. So, but everybody's different. I had no dry mouth. I didn't have the typical side effects. I had the unusual side effects. And since it was, and the doctors honestly told me there's no correlation between how much your PSA goes down and how much your tumor disappears. So I almost say, is this the emperor's new clothes?
How many treatments did you
Yeah.
do?
I bailed out after the 5th because the side effects were getting unbearable. I had other side effects than the ones I mentioned. And the PSM, I think a PSA was going down about 10%, 50 to 35 to 30 to 25, 23. It means when I finish, I'd be down to 15, maybe. Well, so what? Then what? You can't,
But
you're
what
supposed
are
to
you
go
going to
back.
do after? What's
That's the
after
whole,
Pluvicto?
well, that's the funny, not the funny thing. You go back on your failed treatment. You on Pluvicto because chemo and other stuff failed. You don't want to go back on your failed treatment. There's at least 2 or 3 new things. Maybe I'm not trying any phase 2 or 3. I've done that. Messed me up too much. No, I'm not doing any trials. That's for sure. So I'll probably be
Carboplatin or
no, that I was on carboplatin for a month and it made my side effects bad when I was on chemo. Chemo and carboplatin didn't work out, so I got off it. I was on Taxotere. My hair, I lost all my hair, as I mentioned last time. I got on Jeftana, all my hair came back. That's the only good point about Jeftana. My hair came back.
Okay,
Francis, the
let's
small rise in
just stick.
PSA is not.
What?
Tom, let's just stick on the Pluvicto for a second.
Oh, the
Okay.
Pluvicto? Well, I said what I had to say.
Let's stick with Tom on the Pluvicto for a second. How low did your PSA? Where was your PSA when you started?
Okay, it was
55.
7.59.
Oh, mine. Oh, I'm
It
sorry.
dropped to 3.4. It dropped
Sorry,
to
hold on a minute.
1.06 and then up to
Hold on, because somebody was talking. Where was it when you started?
7.59.
7.5, and it went as low, and then it went down to how much?
Uh, 3.46, I think, something right around there. And then it went to 1.06, and then it went up to 1.49.
You can't. So we need to talk about numbers. These numbers, when it goes from 1 point, what did you say? 1 point, what was the lowest it got to?
0.6.
1.06,
1.06.
and then it went up to
And then it went up.
1.49, right?
Yes.
Okay. So I think that these numbers, you've got to give them a chance. These are all very good numbers, and we can't talk about this as in an elevator speech. Well, it went up, but then it went down, but then it went up again. We got to look at the numbers. I mean, ask the guys what they think about these numbers, and hang in. And the treatment is 6 treatments. You're doing very, very well. Nobody is going to tell you. I bet your docs are saying, "Don't worry about it. It's gone from 1.06 to 1.4." Let's see what happens next. I bet dollars to donuts. That's what they're saying to you.
Yes, it is. But they always say that.
So,
It's always happy speech.
Oh, no. They don't always say it. This is your projection. You want this. You're already ahead of yourself, and it's failed. And now what am I going to do next? No, give these treatments a chance. A lot of guys on here would be happy. Don Eisner would have been thrilled if he would have gotten down to 1.06 and then 1.49. And he might have even done that 6th treatment after that, even with his edema. I mean, we're all different.
Yeah.
Guys, can somebody talk to Tom Maloney and give him some encouragement with the way this treatment's going? Someone else
yeah,
who's had... Thank you.
I can mention something here. If I understand correctly, they don't even want you to start Pluvicto until your PSA is above 2. So if your PSA is below 2 and it's continuing to fluctuate below 2, that would seem to me a pretty good sign.
Yeah, of course, when I started, it was 7.59, I think.
Still very good. Still excellent.
Yeah, but you just heard a gent at the beginning of this meeting who's been living with a PSA in the 15 to 20 range for the last 6 years, Tom Maloney. 6 years, and now it's gone up to 40, and he's fine, right? So we've got, now everybody's different. That might be that Rick Dietrich makes a lot of PSA, and so we can't compare directly. At the same time, most of us would be encouraged with where you're going. And when we start getting anxious and we're worried, that doesn't help our immune system, and that doesn't help us get better. So we got to stay positive. I would say you're doing fine. How about anybody else want to say something? Len, I mean, what would you say? You have a lot of experience, even though you haven't done Pluvicto. What would you say to numbers like that?
Well, I guess I'd say count your blessings that it's working as well as it is. For some guys, it doesn't work at all.
Yeah, thank you. Yeah. I just wonder what comes after Pluvicto.
Don't worry about it.
Don't worry.
We will talk to you about what comes next. We will, and we'll get into it. But you've still got 3 more Pluvictos to go. If your PSA goes through the roof and then it goes through the roof a second time, we'll talk to you then. But we don't want to talk to you about what to do next because you're doing great.
Yeah, if you're watching a good movie, don't worry about what you're going to watch next because that hasn't been produced yet.
Yeah. I want to thank all you guys for your support. I really appreciate all of it. Thank you very much.
Okay, I got to throw something in here. Telling somebody not to worry is usually an ineffective way of dealing with worry. Right? I mean, that's a pretty much psychological fact. So we need to be careful telling Tom, just don't worry about it. It is, okay, we have future treatments. And that's what Gainesman tells me all the time. Alan, when you start worrying, tell yourself, no, doctor, I have, future treatments for you. So you don't have to. And I'm not going to tell you what they are now because it'll depend on the situation. But he's got those treatments and he knows what he's going to do. And he's my quarterback. So he'll take care of it.
Okay, so I stand corrected. What I should have said to you, Tom, and Alan's right, I should have said to you, stay in the moment right now. That's what I should have said to you. When I said don't worry, I should have said to you, stay in the moment. Where's my man, Dr. John? Dr. John, can you correct me? Jump in. You're a moderator. You correct me on this. This is your field.
Well, the worry was a reaction to the thought, the cognition that his PSA had gone up. So we can't say don't worry, but we can say, no, your PSA didn't go up. It didn't go up. That little amount of PSA fluctuation is not a clinically meaningful increase. So maybe if you can change your thought and say it didn't go up, it's just rattling around at those low numbers, maybe that would undercut some of the worry. Would you go with that, Alan?
Yeah, I think that's great
Yeah.
insight, Dr. John. Yeah, exactly.
Yes, call it a blip.
Yep, and you have to remind yourself because that worry is going to come up again. But then the self-talk is no, it didn't go up. It didn't go up. I'm mistaken about that. That's a faulty thought. So I don't have to, that should lower the worrying.
Just a blip.
It's just like people who have anxiety attacks. Their
Thank
heart
you
starts
all.
beating like crazy and they think I'm having a heart attack. But once they can get to the emergency room and get the EKG wires on and the doctor can say you're not having a heart attack, that aborts the anxiety attack.
Yeah.
Because it changes the cognition that causes it. So I think it would be reasonable. I mean, I'm not a specialist either in that field, but I think it would be reasonable to say it didn't go up.
Very good.
Thank
Okay,
you.
Tom. The main thing is you're tolerating it and keep going. Hang in there. We love you. Okay.
I just wish I could give everybody a hug. Thank you so much.
Oh, we feel it. We feel it. That's why we're here every single week. Pat Martin, can we give you a hug?
Yeah, quick update. I had a biopsy yesterday, and they fitted me in another place. I got fitted for radiation simulation, and I will have my radiation next week on Tuesday. Tuesday next week, the 16th, I'll have radiation on my lower spine, my lumbar area, and it'll be one radiation session. And I asked him, I said, I was expecting 5 or 8. He says, we've done a lot of studies on it. We found one at the dose I'm giving you will be just as effective. It may not be as long lasting, but we'll treat that when we come to it. So one treatment next week. So be good to get rid of some of the pain. So that's where I'm at.
Are you taking narcotics for the pain?
Yesterday was the first time I was pain free for months. I never realized how wonderful it felt. So, and I told that, I emailed my team today, and they've given me a prescription where I can take 10 milligrams of oxy every 4 hours. So, yeah, I'm on narcotics.
Is it the pelvic mass that they're shooting at, Pat?
I'm sorry?
What are they shooting at? Where are they? Is it L2, L3 that they're shooting at, or the pelvic mass? What are they
Yeah,
going?
no, L2, L3. And what they biopsied was a lymph node on my left side, lower back, um, laid on my stomach, and um, it was a guided biopsy, of course.
Okay. And didn't you have two masses, as I remember? Am I right?
Well, I've got a mass inside my bladder that's about
Okay.
bigger than my thumbnail.
Right.
And then in the terms in the my rad onc, he says you've got a lot of targets in your abdomen that I could be shooting. Um, I've got many um, metastases in my lymph nodes, one on top of each one of my adrenal glands. Um, so yeah, they've got a lot to shoot for. Right
I
now,
mean,
they're not the
Right
ones
now they're
causing
going
the
for the
pain.
pain. Right now they're going for the pain is what what we're
They are
getting.
going for the pain,
right.
and they've got me hooked up with the palliative care team. So I'll see them probably on the same day I do my radiation. It's in the late afternoon, so I can see palliative care in the morning. So,
Okay. I mean, that's good to get those guys in there because they can help you with the symptoms. What I'm concerned about, and this is really what I hoped you would discuss with Schweitzer, is that um, some of these other spots, um, the disease could be morphing. We've talked about that. It could be changing. And so the more
very
of
much so.
these spots that um, we can see, then and biopsy, then the more chance we've got of finding out if it's morphed somewhere, because
Hmm.
it's pragmatic. It could morph in one place, but it might not morph in another. And so the discussion to have with Schweitzer is, how many easy spots are there to biopsy so we can see if this disease is morphing?
I agree with that very much.
And what did he say?
I haven't talked to him directly. I I got to go through the emails, and um, I did not approach it that clearly with him. And like Peter said, they're just looking right now at the pain, trying to get that dialed down, and because I've been kind of miserable.
And you
Yeah.
didn't get the result of this latest biopsy yet, is that right, Pat? This is John.
No, it was just done yesterday, and they figure
Okay.
a week or so, week to 10 days.
Good.
Because that's at least one spot that will speak to Rick's concern.
Right.
Yeah,
Okay.
yeah,
Well, we're thinking of you, Pat. I mean, this is a tough spot you're in, but we certainly
yeah.
care about you.
No, I appreciate all your input. You guys are great. I hold you in high regard.
Okay.
Thanks.
So, Pat, may I say something?
Yeah.
Sure. Go ahead.
So, Pat, I just want you to know if you're going to be taking that pain med, it's going to have a cumulative effect, probably, of constipation. There's not a lot you can do about that. It's quite a nuisance. But if you eat a big old bowl of oatmeal, put some butter on it. and some maple syrup in the morning, 1 time a day, a big bowl of hot oatmeal. That's going to help you with the constipation that is going to come from taking that pain med.
Yeah, I've talked to the doctors already about it. My pharmacist, it's a local pharmacy. Um, they know me by name. I walk in. It's kind of like Cheers. Hi, Pat. And hand me the drugs over the counter, and they know me very well. So I've already talked to him about what kind of laxatives, and I've been doing chemo long enough. I I've been dealing with constipation or diarrhea one side or the other right along. So, and I know the narcotics constipate you. It just stops the peristaltic action in the bowels.
Yeah.
They just don't like moving things.
Right.
So,
Yeah.
thanks for your
These drugs are a wild ride. Thank you, Pat. Thanks, Rick, for the oatmeal
Thank
tip.
you.
Yeah. Okay. Harry, you had a quick update or something?
Yeah, I just wanted to mention I had blood work done for my PSA and testosterone, and my PSA is undetectable, and my testosterone is slowly inching back up. It was 85, and the reason that's important to me is a year ago I went from a combination therapy to a single therapy. I was on Zoladex and apalutamide, and then changed from apalutamide to darolutamide. But the fatigue was knocking me out severely, and so I decided to go to one drug, and so I dropped the Zoladex and have been on the darolutamide for about a year now. So things are holding steady, and I guess unknown territory as far as my oncologist tells me. Not really, she would prefer me to be on both, but that just made life very difficult for me to function on both of them. So I feel good that things are holding steady. So that was just the update I had.
Yeah. Well, good. Several of us have done darolutamide monotherapy just by itself. I know it's not a common regimen, but a number of us have done it. Len's done it. I've done it. I did it for 2 years. Yes, it's not out of hand. It's effective.
Yeah, it's working so far, and I hope to get some testosterone back, and that'll help me feel a little bit better too. So that's kind of the game plan right now.
Yeah, Len could probably speak to the testosterone gain with it, right?
Len, you're muted,
Yep.
Len. Go
Yeah, sorry,
ahead.
guys. Sorry. So, oh yes, on darolutamide, my monotherapy, my testosterone tended to be about 400. So, well into the normal range. And fatigue was almost non-existent, although this happened to both Peter and myself. After about 2 years, we did start to feel fatigue from darolutamide monotherapy. So hopefully that won't happen to you, but just keep it in the back of your mind.
Yeah.
Like Peter, my PSA was kept very low, below 0.1 for let's see, I guess I was on darolutamide monotherapy for close to 2 years.
What happened after the 2 years? Did your PSA start rising, or?
No, it was like 0.02. And then because I started feeling fatigue and I had been at a very low PSA level for a long time, my oncologist and I decided I would just go on a complete drug holiday, thinking that I would probably, need to be back on therapy in 6 months or so. But here I am now, like 15, 16 months on drug holiday. Yeah, and it has managed to stay low.
Great. Wow, that's great.
And
And
David Muslin just came in right on cue. I think he's in an aeroplane flying somewhere, but
Oh, wow.
I think he can hear me. I don't know if he can come in, but he's been on monotherapy darolutamide. David, can you put your camera back on for a second? I saw you for a second there, and it turns out that there you go. Oh no. So maybe he lost the connection. But the Shmulewicz has two guys on monotherapy darolutamide. That's it, and they're both doing real well because I know David spoke to him about that. So he may be on his way back to Chicago right now. You can go have a cup of coffee with him and talk about it.
Right. So good.
Okay. Well, very good.
Yeah, I just wanted to say when I was on enzalutamide, I had a side effect of really bad fatigue, but I've been off enzalutamide now for a while and on darolutamide. Only about a month, but so far, absolutely no fatigue whatsoever with the darolutamide.
Good. Good. We all react a little bit different, and you got to keep monitoring it as you go along. Mike Yancey, up to you.
Okay, so it's a quick update. Of course, as you know, I've been fighting two different cancer mutations, two different fronts. I've been fighting a non-PSMA producing, non-PSA producing cancer on my spine since late last year, turn of the year. And so we had some proteomics done, analyzing the proteins, and found that a chemo regimen of etoposide and then adding carboplatin to it would probably be the best option. So we've been using that. It's been working quite well. Had a scan today, and we did find some growth down on the L4, L5 on my spine, but we won't know at this point in time whether it is a PSMA producing or non-PSMA producing until I get my gallium-68 scan next week. Because in my hip area and pelvis area, that historically has been the PSMA, PSA producing cancer, if you will. And since I had to stop Pluvicto in December when we started the chemo, we've really not had anything that has been very active towards that particular cancer. So I'm actually also starting radium-223 this next week to try to knock that back down, and just throw in a little extra. We're also going to start back next week. So that's where I'm at, and I'm looking very forward to the gallium-68 scan results to know more.
Okay. Is there anybody else on here that's done radium-223 in recent history? I don't think so. It's just starting to come back a little bit after Pluvicto, but I don't know many people that have done it yet.
Yeah, I mean, I think Tom Hope's interview last month really spoke up for the space for radium-223, and also the fact that it's a different type of radionuclide to the Pluvicto, so they can work together. With the shortage of Pluvicto, which still hasn't resolved itself, it makes radium-223 a much better, a much more attractive option. The downside is that it only goes to the bone, as opposed to any place where there is PSMA expressed. But I think for somebody like Mike, it's a real good option because he doesn't have He doesn't express PSMA everywhere. So, yeah, I mean, I think we'll see more and more of it used. And Len and I have been talking a little bit about Pluvicto, about radium-223, because we feel that Bayer needs to be marketing into that space. And Len, didn't you just write something up on radium-223 in patient language? Can you put a link to that? Is it out yet?
Yes, it was published in Future Oncology. I can't put, I'll try and find the link. I'm not sure I can find it right, in this session, Rick,
Mm-hmm.
but maybe for the next session. But yes, the only, radium-223 got a bad rap years ago because in a trial, there were an increased number of bone fractures, excuse me. But then they realized you had to be on a bone strengthening agent like denosumab while you're taking radium. So make sure that's Xgeva or denosumab. Make sure you're getting a bone strengthening agent when you get the radium-223. But it doesn't cause the same degree of bone marrow suppression that Pluvicto does or that chemo does. So that's a good thing. But like Rick said, it's strictly for bone metastases. If you have soft tissue metastases, it's not going to be effective for those lesions.
Len, what's the reason? What is the reason that it is easier on the bone marrow? Is it something to do with the length of being an alpha versus a beta, or what? Why is that?
Could be that could be, Rick, because the alpha, which is what radium-223, an alpha emitter, it's a more powerful radiation emission, but it's extremely small. What's the right word here? Extremely small radius of action. It's only like a couple of millimeters, which is like a couple of pencil points. But the beta emitters, like Pluvicto, cover a much wider area. So that's why you would tend to have more bone marrow damage to healthy cells, potentially healthy cells.
That would make sense. That would make
so
sense.
The Bayer paper that we did the patient language summary on, the thrust of the paper was that Xofigo or radium-223 should be used before chemo. Once you've taken chemo, your bone marrow's already taken a hit. And then, radium-223 is going to have some additional damage to the bone marrow. So you wanted, if at all possible, you want to do it before chemo.
Okay.
So Ben has posted something, but only to the organizers. Ben, can we put that out for everybody? Len's paper there.
I wanted Len's go ahead. I wasn't sure whether that was the one.
Yeah, that's it.
Okay.
That's
Okay.
it. Thank you, Ben.
Look in the chat window and you'll find the link.
In a minute.
Okay.
Anything else for Mike Yancey? Anything else that we can help you with, talk to you about?
Good for now. I appreciate it.
This brings up
Okay.
a question.
Go ahead, Larry Fish.
So let's say that you had chemo, like I did 6 years ago. Does the bone marrow rebuild and then you become, you'll be more eligible for radium-227? Or that's permanent and you don't rebuild after a long period of time?
No, your bone marrow should recover after 6 years, unless you're taking some other drugs that are also suppressing your bone marrow.
Yeah. I was just thinking after, even though you may have had chemo, and then years later you're having metastasis again, you might be eligible for radium.
Right. It depends. If a lot of the time your blood count, your CBCs will kind of indicate whether, if you've got low red blood cell count or hemoglobin, consistently low like me, that there's already damage going on in your bone marrow, and it's probably not going to recover very well. But
Yeah,
if you've got a
Peter,
strong blood count, you're probably good to go, is my
good
guess.
point. Good point, Peter. Thank you, guys.
Okay. Kirk.
Yep. Sorry,
Go ahead.
finding mute. Quick update. Had got my PSA test back, undetectable, less than 0.01, and testosterone also undetectable at 7. So that they're both all good, just inconvenient. And I see Anton and Arcus tomorrow to discuss that. So otherwise stable, no changes. I roll off of my Lupron. Probably the end of June will be the kind of the closing date of the current dose that I'm on. So that's it.
Those are good numbers, and so it means the Lupron is still working. I know because I'm looking at my notes that you are one of these very unusual men who has a BRAF mutation, BRAF
Yep.
mutation,
Yep.
and so it's going to be interesting. I know in the past that Dr. Antonarakis has talked about a particular drug that addresses BRAF mutations. Ooh. You may have lost me for the second. I don't know. Can you hear me still?
Yes.
I can hear you. Everyone's video just went out.
Yeah. Okay, great. So, I think just keep digging down with Dr. A about his thoughts on anything new with the BRAF mutations, because this is great for us because it's not something we hear about. It's it's very interesting to us, and we hope it will be something very worthwhile for you too.
Yeah, well, I hope they don't have to use anything that's developed for melanoma chemotherapy, simply because I'm counting on that I'm cured. So.
Okay. Anyone else have anything they want to ask Kurt? Going to see Dr. A tomorrow. Of course, Dr. A is now Peter's man as well. Send regards from Peter, right, Peter?
Yeah, I'll be seeing him on the 12th of June. I've already made an appointment for my next infusion. The second to next infusion. Yeah.
Hey.
Yeah, he's the man in terms of mutations. I mean, he's got it upstairs for sure. Okay. Jeff Marchi, you had a quick update of something or a question, yes? Jeff Marchi, you still with us?
Looks like he's trying.
Turn your volume up. Turn the volume up.
I can see your lips moving. We can't hear you. Turn the volume up. Okay, we'll come back to you, Jeff. Hang on to that thought. Lynn Lindsay.
Thank you. First, I think the expression is a shout out, but a thanks to Rick Davis. When I was on for the first time 2 weeks ago, he introduced me to the concept of the G, or the genito-urinary medical oncologist, and also the name of this fellow Oliver Sartor, who started on April Fool's Day in Mayo. I have established contact, and I look forward to meeting with him, I hope, in the next couple of weeks. So, secondly, Peter K., thank you very
Can
much.
I be heard right now? I just want to know.
No, we hear you. Hang on. Okay.
I know, but I wondered if
we hear you. Good enough. Okay.
Peter K., thank you for having given me the information about the PROMISE genetic testing. I've also received the kit, KIT, the kit from them, and I've submitted a sample, and I think it'll be helpful. So thank you. I've already put to use the information that I gathered a couple weeks ago. I don't think it's relevant. It's only relevant if it has any relevancy, which I doubt, at least in the minds of you all, but I'll ask. It turns out, since the last time I was here, and the only time 2 weeks ago, I was diagnosed with, I think, a fairly minor matter called basal cell carcinoma of my scalp. And the context in which it's a slow growing, very slow growing, but I guess it can be problematic in the long run. But what they're suggesting, they being the analyst, the doctor, is suggesting is that I submit either to a surgery, all right, to remove it, or something that you all might be a little bit knowledgeable about, something called image-guided superficial radiotherapy. And I'd be curious to know if anybody's heard about it and in what context, and how that stacks up. I've already had a lot of radiation, 33 refractions a long time ago. I've been advised that this IGSRT is not a big deal. It takes place over 7 weeks, 3 times per week, and should not be a problem, even though I've had a lot of radiotherapy in the past for cancer. So is there any thought at all about a relationship with carcinomas and radiotherapy? I'm guessing not.
We're talking skin cancer to your head is what you're
That's
hearing.
correct. That's right. Correct.
So one, get that PROMISE study swab in, and you'll get the results back pretty fast. If it was me, I would not act on the basal cell stuff until I got an answer back, because if you've got multiple cancers going on, even though it's just basal, you just want to know that there's nothing driving this thing that's genetically related. That would be my take on it. I'm not an expert, but if it was me, I for sure would want to get that information in the bank before I submitted myself to radiation. Anybody else have a comment?
I'd endorse that. If it were me, I'd wait because there is a relationship between melanoma and prostate cancer, and in terms of mutations, and I just want to be sure that there was nothing more going on. So if you have a little bit of time, just hold on, and it's certainly something that when you get your appointment with Dr. Sartor, he's going to be able to talk to you about as well. He understands that relationship very, very well. So I think I'd agree. I totally agree. I mean, we can't give you medical advice, but that's certainly what I do, and that's what Peter would do. I'm very curious, Lynn. What was the process? And I'm asking you because this will apply to other men. What was the process like in trying to get the appointment with Dr. Sartor? Was it easy? Was it just like falling off a log, or did you have to jump through hoops? Can you tell us?
Or not falling off a log, jumping through hoops, talking to a couple of personnel within the appointments area. So, for example, I'm already a client of the radio oncology side, and so it took me a while to figure out I really had to apply as a new patient. A new patient where? Well, in Mayo, but in the so-called oncology department. And it was difficult for, all right, number one. Number two, you're right, Rick. Sartell must be a fairly new entree. Yeah, that's not like something you eat. He's fairly new. His GU status as a medical oncologist has to be fairly new. I doubt they have very many, if any, other like him there. Um, so, for example, he's not really formally listed yet as to for making appointments. So you have to really, I had to really drill in. Well, I said, gee, I know he's been there since April 1. Are you sure? And so finally I was passed over to someone who works with this fellow Sartell, who normally does not attend the telephone answering side, who said, yes, but Dr. Sartell is not quite through the introduction. He hasn't been quite run through Mayo's setup. There's a better way of describing it. He's not quite taking appointments yet. However, Rick, he does have a few already on his waiting list. So, frankly, I have to call back in a couple of days to affirm the tentative date I have with him, which should be fairly shortly. And one other thing I'll just mention in passing, and it had to do with the comment that you made. No, maybe it was Rick. No, I think it was you made about Dr. A. Antonarakis, and if you've already been working with another doctor in that unit, if there might be a difficulty in one medical specialist in the same department getting his nose been out of whack. All right, if I can use that expression. If you go to another one, I shared with the telephone operative whom I spoke. I said, I already see a radiation oncologist. Do you foresee a problem? Does that there will be coordination between these two different areas? It was right out of the right field. Will they even respond to such a question? And there was sort of a hesitation on the person's side, and said, no, she said, it's true that we haven't seen a lot of the patient comes first, but we haven't seen a lot of collaboration. But I don't think should be any problem with collaborating between the two doctors. But I am a little concerned about that because I have a long history with the rad-onc whom I've seen for a long time.
Yeah. Well, let's see. Keep pushing. Len, did you learn anything when you spoke to Dr. Sartor over the weekend about getting appointments? Is Len still with us?
Who are you speaking to?
Len.
Len got bounced out, I think.
Okay. Yeah, he's been having problems with his connection. So Len was at the CancerABCs conference in New Jersey over the weekend. So was Dr. Sartor. Len, it's Sartor, Sartor, and one of the things I asked him to do was to check in with Dr. Sartor to find out about how people who are already in Mayo get to make an appointment with him. So, but I'm sure we'll have the opportunity to talk about that again next time Len's back with us. So, okay. Well,
thank you.
Yeah.
Okay.
No, I mean, please keep us posted.
I will.
Okay, and Len, I look forward to meeting with you and your brother next month. And
agreed. Thank you.
Yeah, maybe we can even include Kirk on that one too. I mean, we got a whole Minneapolis Twin Cities group forming right now. Okay. Go ahead, Jeff Marchie.
Hello there.
Go ahead.
By the way, about an hour into the meeting, I saw a command issued that took away the users' information, and everybody's attendee except the organizers. Attendee 2, 3, 4, 5. Does anybody else see that? That we don't have usernames anymore? Yeah. Somebody issued a command to turn them off, and we lost everything. Just want to let you guys know. I don't know what I don't remember what the command was.
We don't have the ability to do that. So
well,
I don't know
somebody
what's
did it.
going.
Yeah, I saw the command issued to do it on the screen. All right, well, let's go on. I think you should contact the people running your running this thing to find out. In September, my PSA was undetectable. By March, it had gone up to 0.7, going up almost every week. In April, I had, after a lot of back and forth with my oncologist, I was able to convince her to let me get a PSMA PET scan. And because my PSA was 0.7. Well, in April, my PSA dropped to 0.4 3 days before the PSMA PET scan. And I know the results aren't good if you're below 0.7, and I'd rather wait for that. Another reason is they keep recommending that you do not have a PSMA PET scan if you have a reoccurrence. Well, sure, I can see if you've had, this is my 5th reoccurrence. At 13 years, the 5th reoccurrence, I think it's about time I had a PSMA PET scan. I am going to get one as soon as I'm above 0.7. Now, I did some changes a few months ago in order to try to get my PSA to stabilize. I know that a lot of what you eat, I read about it, I hear about it constantly. We've had meetings about it, that what you eat is a big deal. Red meat especially is very bad for you. It couldn't be much worse to have red meat regularly. Over the last year, I've convinced my wife to make more fish, chicken, and turkey dishes, and she likes the fact that I cook some of the fish dishes too. I also removed any fat I can see in whatever I'm eating. I used to eat, my PSA went all the way down to undetectable, eating 2 eggs every day, but they say eggs can cause a problem, so I'm not eating more than 2 a week now. But May, I went for another another PSA test and dropped from 0.4 to 0.2. So it might just be what's going on with Abby. Abby is unreliable, but in keeping you consistently low, I'm on it for almost 2.5 years now, and I'm satisfied with 0.2 for a while. But as soon as I hit 0.7, I do want that PET scan. But I'm not sure that changing my diet has made a big difference, but it seems to have come up at the same time, and well, that's about it.
Very good, Jeff. And I'm glad it's down to 0.2. And it's a good thing Rick Dietrich from Wyoming isn't on to hear you talk about getting rid of red meat.
He still is.
Is he still on?
Yeah, he's a 10D2.
I don't know. Oh, okay. Or 32. Okay. That's controversial. Red meat is controversial. Some people say no, some people say yes, but yeah, diet is one of the few things we have control over. So good for you. Tom first, and Bob, you both have your hands up.
Okay, thank you. I just questioned the wisdom of waiting for your PSA to rise. If the Red Sox are leading the Yankees 10-1, do they wait for the Yankees to catch up? No, you just go ahead and keep going. I don't know why you wait for your PSA to rise. It doesn't make sense to me.
Well, it's got to be high enough to make the PSMA scan work.
Yeah.
If it's down too low, it won't show anything.
No, it won't work. It won't work, Tom, because it may work. The problem is that when the PSA gets down to that low, the likelihood that you're going to get a result is less than 40%. And because they've done the statistics and they know that to get a reasonable result, your PSA needs to be around 0.65 or higher. And they've done it. They've looked at it statistically. Now, Jeff Marchi could get one, but Jeff has a bit of an issue in that he's a patient at Kaiser Permanente, which is an HMO.
No, it was still my choice, Rick. I could have had it. I just said no.
Hold on a minute, Jeff. Don't interrupt, please. Okay. I'm making a point in your favor.
Yeah, but you're making a point not in my favor. not count. It's counter to
Jeff,
what
do me a
Kaiser does.
favor and listen. It's hard for you, I know, but please listen. The reason is that if Jeff goes in and gets that and it doesn't show anything, it's going to be hard for him to get another PSMA scan quickly when he goes back up to 0.7. So he's got like one shot maybe he can use this year. He chose not to do it. He could have done it at 0.2, but he says, I'm waiting to see if I get better odds. Okay? Am I right, Jeff? I mean, if you went in and got it at
Absolutely.
0.2,
Okay.
Absolutely. That's exactly the reason why
I
take a chance
know.
when it might not show anything and much less likely to show something.
I know where you're going. You got to listen. Let me finish. So that was the reason why, Tom. So I hear what you're saying. If you could get, if you were in a situation where you could go get a PSMA scan every week, like you get a PSA test, we would say, fine, let's do it. But these PSMA scans are expensive, and the payers don't always pay for them, and we can't always get them as often as we want. So we have to take that into account. Make sense?
Okay.
Yes.
Yes. Thank you. Thank you, Rick.
Okay. Okay. Bob McHugh, you got a comment?
Yeah, just thanks, Peter. Just apropos to this conversation, Rick Davis, I am thankfully the exception to the rule.
Right.
Dr. O had me do, you know Dr. O well, he had me do a PSMA scan about a year ago at 0.5, and it showed lesions on my pelvic lymph nodes, and I had radiation, and I currently am on what my new med onc is calling active surveillance. So it can be helpful. There's no hard and fast rules, as I'm sure you'll agree.
No. I mean, it's just playing the odds. I mean, if the odds are just lower of you seeing something. But if you're in a situation where you can come back 3 or 4 months later and get another one, it does, why not? But if you're in an HMO where they're passing these bloody PSMA scans out like they're gold dust, you gotta sit on it a little bit. But I agree with you. I mean, you may get a result like you did.
Right. Thanks.
Okay. Jack, Dr. Jack.
Yes. Okay. Let me ask a sort of an academic question because I'm a little confused about PSA and tumor burden. I hear people saying there's no correlation between the two, that if you could have a very low or non-existent PSA and that doesn't mirror the tumor burden. And yet on the other hand, we're talking about, you're not going to be able to get a PSMA scan if you have a low PSA. And it seems to me, contradictory because if you can't get a PSMA unless your PSA is higher, that would correlate with a higher tumor burden that's more visible. So I'm a little confused about those two terms. Maybe somebody can clarify.
Some people don't produce PSA. So, I mean,
What?
Some people don't produce much PSA.
Well, I'm not talking about those people. I'm talking about in general that, you say, the higher the PSA, the greater the chance the PSMA is going to light up if you're PSMA avid. But on the other hand, people are talking about there's no correlation between PSA and tumor burden. So I'm confused.
Well, the reason they say that is because that they are totally unrelated concepts. The PSMA is an expression of protein on the cell, and the tumor burden is a function of the little flakes, SNPs of tumor that flake off and go into the bloodstream, and then they get measured. So the more flakes we see in the bloodstream, the higher your tumor burden. Okay, that's the tumor burden, the tumor burden fraction that they give you in the blood report. Now there may be other definitions of tumor burden, meaning how many tumors you have, but that's what I think of. We lost Len, and he ain't back. What about Ben? Ben. come to my rescue, Ben, on tumor burden and PSMA for Dr. Jack, please.
I'm struggling here too.
Yes.
I was hoping Len would be here.
You're struggling too.
We
How
could think
about
about that.
Jack? Dr. Jack? Dr. John,
Yes, sir.
rather. Dr.
Well,
John.
Rick,
Len
Len
is
is
here and
waving at
waving
you.
his hand.
One at a
Len
time,
is
one at a
back.
time.
Len's here.
Go ahead, Len.
Yeah, I think you had it right, Rick. The tumor burden, I think we associate with the liquid biopsies, and they're measuring the either the cell-free DNA or the circulating tumor cells. And that is different from the type of cancer cells that are lighting up on a PSMA PET scan. I think
Maybe we should
the
call.
term for a large tumor burden within your tissues, I think would be they would say high volume as opposed to high tumor burden. Anyway, that's my take. I'm not sure about that.
Well, maybe
It
we
would
can
be.
give it
It
some.
might be helpful to say tumor mutational burden instead of tumor burden.
Well, I'm just talking about a PSA. Someone said before there's no correlation between PSA and the amount of tumor that's present in your body. And you would think they talk about shrinking tumor with ADT, and therefore your PSA gets lower and lower, and testosterone goes down. Your tumors get smaller and shrink, and therefore I would think that's called a lesser of a tumor burden, and that correlates with the PSA. But maybe it doesn't.
Not really. Not really, Jack, because that's the reason why when you get into the realm of advanced cancer, they always tell you don't rely on your PSA. You've got to go to scanning. Scanning is much more important than the PSA because your PSA can go up, it can go down. You've got some people with this morphing disease that don't make PSA. You've got other people that have large PSAs, but you don't have a lot of tumor. So there's such a variation in how much PSA you make.
I get that. But let me catch you up on where I'm at since you asked me. Okay, so as you all know,
quick, Jack, go quickly.
Okay, so I had an ablation. I had a reablation, so I'm now off the Multec.
Good.
I've been off the darolutamide that I had been taking for 3 weeks prior to the ablation. I went off for 4 days. I went back on it, and for 5 days of being on 300 BID, I repeated my PSA, and I couldn't believe it. Went from 2.01 in March to 1.12 in April, and yesterday it was 0.063, which is about what it was when it was barely detectable 5 years ago. So I asked Belusic, could this be possible with 300 BID of Nubequa? He said, yes, it could be. And wait till you see when you go up to 600 today. So I went up to 600 today. It's my first day at 600. And he said, let's hit it hard as hell. And then let's see in 4 weeks what your blood tests show. And if everything turns out okay and no liver crap or QTCs or anything else, we'll go with either the Garelix or Orgovix. So he's going to give me a choice. He said the Garelix, he said, would be preferable because it doesn't go through the liver. And but he said if you feel more comfortable with the Orgovix, do that. So that's where I am. In addition, SBRT was supposed to begin today, and the machinery went down, so I'm not beginning until next week. A linear accelerator versus the MRI, the Meridian MRI. I don't even know what's better, but I think they're going with a linear accelerator. If anybody knows anything about that, could tell me which is better. You can educate me because I have no clue. And also, he's going to do 5 fractions, 3 on the hilar lymph nodes, 3 lymph nodes, and he's going to do five fractions on the hilar lymph nodes, and 3 on the L4 pedicle and the left rib, and That's my up-to-date status. I'm just hoping for the best.
Great.
Any
So
comments?
just one quick comment is that the Garalex is not a very comfortable shot.
I heard.
Yeah, so that's my only experience. Len did quite a
I-
few of them. I mean, Len's was the champion of them, but I
Yeah,
didn't like. I only did one, and I didn't like it at all.
yeah. The more you get them, the worse they get.
Yeah.
And this happened to me, and I know it happened to a few other guys. Once you get past like a year of taking those shots, you tend to run fevers after you get the injection.
Okay.
The swelling and injection site pain becomes worse. It's
I'll just
you're
pay
better
the
off
money
with
and
Orgovyx.
pay the money and the Relugolix. I like the idea of being able to get off of it too.
Yeah.
Yeah.
If I
Right.
need to. Is there any possibility, or is it just unrealistic to assume that that I can continue on, monotherapy with a Nubeqa? No, it won't work. Just too much testosterone, too much estrogen, too much gynecomastia, too much whatever results of hyperestrogen. Has anybody ever done darolutamide without ever doing
We
Relugolix?
talked about that in this meeting just a few minutes ago, Jack. We
I
had
heard you. You
you
said a
know,
few people.
so there's a lot of people have done it. Len has done it, and David Muslin's done it, and Peter's done it.
After doing ADT though.
Yes.
Um,
Yes.
Nobody's
yes,
done it. Nobody's done it from the get-go.
um,
Solo.
don't know. I'd have to look and see if anybody's done it from the get-go.
I don't think
I've
it's
never
standard
heard.
of care. It would have to be a
Yeah.
pretty odd doctor that would go with it. Yeah.
I agree. But both guys, Belusic and Danila, both said to me, you can't do that alone. But I was just wondering if anyone's ever done it. Thanks,
Yeah, I
guys.
think everybody I know has switched to it. They've dropped the ADT, they've dropped the LHRH. So right now you have not taken you haven't taken any LHRH?
No, remember I couldn't take it because I was
Right,
on Multac.
right.
So now
So
I'm off the
a couple
Multac.
of things. One, I'd lean on Belusic and say, look, I'm down. This is where I am. I'm down. Can we keep trying it? Can we see? And see if he'll go with you. He's pretty flexible, and he might allow you. The other question I wanted to ask you, because I've been looking at this in the last few days, is have you gotten on your insurance? Have they told you what it's going to cost you for
Relugolix?
Relugolix?
No, I think it's 3,600 a month. And I
Okay,
think it's out of pocket 800 because
I
of the
don't think
Medicare.
it's going to be as much as that. I would be very surprised. But it might be a high number. The highest I've seen so far is around 1,200 a month. And then, you pay that until you get through the donut hole,
So,
and then it doesn't cost you. So you have to get through the donut hole. But most of the guys, I've had answers now from 10 or 12 guys. And if they haven't gotten any subsidies up front, they've been paying anywhere from about 700 to 1,200 for the first 2 or 3 months.
got it.
Okay, guys.
Thank you.
Honor.
I have a question for Len. Len, you dropped off. Did you have a chance to talk to Dr. Sartor about how patients can get to see him if they're already in the Mayo system?
Unfortunately, I didn't, Rick. He was virtual only, and when Jan Manoright was moderating that session, and she kind of hogged the microphone, so I didn't get a chance to get a question. However, there was one thing he mentioned, which may or may not apply to anyone on the call right now, but he said he routinely uses a docetaxel regimen of 50 milligrams per square meter every 2 weeks, rather than 75 every 3 weeks. and he said he's seen less side effects and equivalent efficacy. So
Interesting.
something we should remember to tell guys if they're about to start docetaxel.
Very interesting. Yeah.
It would be nice if he would put that in the form of a letter to a journal or publish it in some way.
Yeah.
That's kind of important, I think.
Well, we've seen it before. I mean, we've seen guys that get put on that lower dose every 2 weeks. I mean, I'd have to go in and search for it, but we've definitely seen it before. The guys that don't do well, they on that 3-week dose get reduced to a 2-week dose, and it's a lower. I don't know the amounts. I don't know the amount per square inch or whatever the measure is.
Yeah.
But
Square meter of body surface.
Square meter or body surface. But I've definitely seen it. I've definitely seen it before. And
then
yeah,
I asked Dr. O what he thought of that. He said, yeah, sure, I've done that too. And he said, I've even done 25 milligrams every week.
Yeah.
So, you know, you got to be flexible.
Yeah. Particularly with other kinds of cancers. I've heard of that with breast cancer and other things. Yeah, for sure.
Yeah.
Okay,
Very
guys,
good.
we're at the end of our hour, or 2 hours.
Hold on 1 second, Peter, because we got 5 minutes at least. I'd like to visit with Len and ask him to give us a quick rundown of anything else from the CancerABCs. How did it go? Did they love you, Len? Did you meet people? Tell us. Did anybody ask for your autograph? Tell us about CancerABCs.
Yeah, it was a great conference. I didn't like having to travel to Jersey City from Connecticut. You got to use either the Lincoln or Holland Tunnel, and they're always congested. But anyway, aside from that, it was a good conference. We had Oliver Sartor, we had Ash Tawari, Scott Tagawa, a bunch of really prominent oncologists, and I became closer friends, shall I say, with Joel Nowak, who, in case the guys don't know him, he's the founder of CancerABCs, like Rick is the founder of CanCan. Joel is a 5-time cancer survivor, believe it or not. And then I don't know if any of you know a group leader in the New York City 0us2 group. His name is Jack David Marcus. He's got Joel topped. He's got 6 cancers. Guys are unbelievable, really inspirational. He's a super nice guy too. Yeah, it was nothing earth shattering or not much I hadn't heard before, but it's just good to meet other cancer advocates, and it was well worth my time.
Great.
Yeah. I may have written down a few other things that aren't coming to mind right now, Rick.
That's okay. And was there a good attendance in person or not?
There was about 100 in-person attendees, less than they wanted, but I'm sure ANCAN gave them a nice boost. Certainly, Jan attributed a nice boost in the online registrants right after ANCAN promoted the event. So she was grateful for that. And Joel said, so Len, can we write you in for the next CancerABCs conference, which I think is going to be in Florida? So I told him yes.
Even if it's in the villages, Len?
Yeah, that could be a problem. That's why I didn't go to the last one.
I know. And what were you doing? What was your job?
Oh, I moderated the session with Scott Tagawa and with an MSK medical oncologist in a New Jersey branch office. His name was Will Rafelson. I hadn't heard of him before.
I know him. He was
You do?
Mark. He was Mark Hornstock.
Oh,
He's in Monmouth. He's in Monmouth. He's in Monmouth, and yeah, I know exactly. He works with Jonathan Rosenberg. Yeah, I know exactly. How did you find Rafelson?
very nice guy, very pleasant. I didn't find him to be as effective a speaker as Tagawa and Sartor, but he seemed to know his stuff. He kind of read through his slides, not really looking at the audience, just looking at the projection of the slides on the screen. So it was a little bit difficult to moderate the session, because when my job as a moderator is to interrupt anytime I think the audience may not be comprehending what's going on. Like I have to dumb it down a bit. And usually if the speaker is addressing the audience, you just raise your hand, Dr. Tagawa, I want to blah, blah, blah. Whereas with Rafelson, I just had to, cry out between his slide changes, Doc, I got a question, or whatever. But it was a good experience.
Very good, Lynn.
Okay.
Yeah. Okay,
Thank
with the
you.
end, you
Just
didn't
one
get
more
my
thing.
update. You didn't get my update, but I'm gonna have to keep you guessing. Maybe another time. Okay.
Okay. Just one quick note, Rick, and the whole group here. Anytime I go to any cancer conferences, I'm always impressed with how much this group knows. This is one of the most knowledgeable groups in the whole country.
You
The
got it.
members of the
Betcha.
other groups and the leaders, they don't know as much as this group knows. So you guys are in the
Thank
right
you.
place.
That's because we have a brains trust with Len and with Ben and
Amen.
Dr. John and with the spirit of Herb, God rest his soul.
That's right. That's right.
Amen. Amen.
Goodbye,
Yay.
everybody.
We have time for you.
Amen.
All right, guys.
Good night, guys.
Night.
Night.